We all know that beta blockers have been used for the treatment of myocardial infarction since many years, based on trials performed in the early 80s, where the treatment for patients with myocardial infarction was very different from today. There was no systematic reperfusion, no complete revascularization, no dual antiplatelet therapy, no high-intensity statins, so treatment was very different. Today, management has changed a lot, so therefore there is the question whether beta blockers would work according to current standards. We know from other trials in broader populations that beta blockers are beneficial in patients with an ejection fraction below 40%, but the benefit of them in patients with above 40% is still not clear. So this was the basis for our REBOOT-CNIC trial, in which we enrolled patients after an uncomplicated myocardial infarction being discharged from index admission with an ejection fraction above 40%, and they were randomized to beta blockers yes or beta blocker no. We enrolled a total of 8,505 patients, which is the largest trial performed ever in the topic. They were enrolled in 109 hospitals across Spain and across Italy. The primary outcome of our trial was the composite of all-cause death, reinfarction or heart failure, and the median follow-up was 3.7 years. The main results of our trial is that we found that beta blockers were not associated with any benefit in terms of the reduction in the primary outcome. The number of patients developing a primary outcome, all-cause death, reinfarction or heart failure was 317 in the beta blocker group compared to 307 in the control group. And we found that this was consistent across all the pre-specified secondary outcomes, which were individual components of the primary outcome and also cardiac mortality. So overall, the main conclusion of our trial is that according to current standards, patients with after myocardial infarction with an ejection fraction above 40% do not clearly benefit from beta blockers. It is fair to also mention that we found a trend for a benefit in the subgroup of patients with an ejection fraction between 40 and 50%. And this is why we team up with the beta-bloccanti block, which has also been presented in the ESC 2025, and we pulled together our databases specifically for this subgroup with an ejection fraction between 40 and 49%. And by pulling together the two trials, we've shown, and this is also already published in the Lancet, that in these patients with a mild reduced ejection fraction, beta blockers is associated with a significant reduction in the primary outcome, all-cause death, reinfarction, or heart failure. So therefore, we can conclude as a take-home message and clinical message that today, according to current standards, patients after a myocardial infarction with an ejection fraction below 50% benefit from beta blockers, while patients with an ejection fraction above 50% seems not to benefit from beta blockers. Still, there was some controversy because we have seen that the beta-bloccanti block have shown slightly different results, because in their trial, in a similar population, beta blockers were associated with a reduction in the composite endpoint, which was wider than in the REBOOT-CNIC, and this is why we are working with them and also with the reduced AMI, and hopefully we are going to be able to have a final meta-analysis for patients with an ejection fraction above 50%.